I'm a clinical postdoctoral researcher in the Department of Anesthesiology here at Stanford University. I do mostly clinical research in my time, but I'm also about 25% clinical, spending time in the pain management clinic. Thank you so much again for giving me the opportunity to present my research to a highly engaged international audience. I also want to give special thanks to Boris Heifetz, who's present for today's talk, and for also extensively mentoring me in my research. My disclosures are very few. I have been supported by NIH training grants, and I have no financial conflicts of interest. I will be discussing off-label and investigational uses of ketamine with a heavy emphasis on peer-reviewed research. As we all know, ketamine was first synthesized in the 1960s and soon thereafter was approved for use as an anesthetic for surgical procedures. But as we all know, in the early 2000s, psychiatrists really started a run with ketamine, showing that it has very rapid antidepressant effects, which hasn't been seen in any other pharmacologic treatment for depression. Across multiple clinical trials, a single IV infusion of about 0.5 milligram per kilogram of ketamine produces clinical response in about 40%, in remission in 20% of patients with treatment-resistant depression at 24 hours after infusion. But the therapeutic effects generally appear within a couple hours after a single ketamine infusion and lasts about 7 days to 10 days. This has led, of course, to an explosion of public interest in using ketamine to treat depression and other psychiatric disorders. In addition to media hype and lots of celebrity endorsements, there are multiple startup companies in the US that ship oral ketamine to your home address for in-home ketamine treatments. Keep in mind that none of this is actually approved by the US Food and Drug Administration. While there have been several clinical trials showing that ketamine appears to be superior to placebo in treating depression, the big problem with a lot of these trials has been masking or blinding. As we all know, ketamine has very potent psychoactive effects that make it very distinct from placebo, as you can imagine. And this leads to the possibility of confounding based on participants knowing what they got and with their expectations potentially influencing results. But going back to the basics and keeping this concern in mind, my research was actually originally motivated by a few other questions, which I'll try to summarize here on this slide. As an anesthesiologist by training, I had a keen interest in optimizing patients before their surgeries, and I initially set out to determine whether or not ketamine could be used to rapidly treat depression to improve surgical outcomes. This is because retrospective studies have indeed found that depression is associated with worse outcomes after surgery. And of course, anesthesiologists have been safely using ketamine as part of their anesthetic cocktails for decades, but few have actually looked into how it affects depressed patients who happen to be having surgery. This led to a more narrow but specific scientific question of whether ketamine is superior as an antidepressant compared to an inert placebo when given to patients who are completely blinded to which treatment they receive in a randomized trial. We realized our study also might shed some light on a much bigger and perhaps harder to answer question, which is whether the acute psychedelic or mystical experience is necessary to achieve an antidepressant effect. Obviously, this is a big question mark for other psychedelic therapies and touches upon the idea of whether maybe non-hallucinogenic but psychedelic-like molecules or compounds are likely to work in humans for depression. Going into our trial design, our design was meant to approximate as much as possible the ketamine antidepressant trials that have come before ours. We recruited patients with moderate to severe levels of depression scheduled for non-cardiac, non-intracranial surgery. We administered a single 40-minute infusion of ketamine at 0.5 milligram per kilo, which is pretty much the standard for psychiatric trials. All participants, investigators, and outcomes assessors and anesthesiologists were blinded to treatment. Really only the pharmacist knew what we were handing out. We measured depression using very standard clinician-rated and patient-rated depression scales in the 2 weeks following surgery, and we also measured a number of other secondary outcomes such as opioid use and pain levels, which we won't cover today in the interest of time. This is just lists of our eligibility criteria presented in full detail. Most notable are the exclusion criteria for active substance use disorder, risk factors for schizophrenia and psychosis, and chronic use of high-dose opioids. Patients with low or moderate dose opioids were allowed in the study. Here is a consort diagram for our trial showing the flow of participants through our study. As expected, 40 underwent randomization, half of them, 20, were allocated to receive ketamine, and the other half were allocated to receive saline, which was our inactive placebo. In both groups, one participant in each group had to be withdrawn or discontinued early from the study for different reasons. But in both of those withdrawn participants, we were able to get our primary outcomes in the first 3 days after infusion, and so 20 participants were included in the intention to treat analysis in both arms. Although recruitment was open to all genders, races, and socioeconomic backgrounds, it's important to keep in mind that the participants we did enroll were mostly middle-aged, majority women, majority white, and majority employed. This is a reflection of our patient base at Stanford University. But clinically, patients had very chronic depressive symptoms with moderate to severe levels of treatment resistance. With regards to psychiatric history, baseline depression severity, shown in the green box down at the bottom, was very similar in both groups. Treatment resistance, which we measured using the Maudsley staging method, was also similar between groups, with about 3/4 of patients having moderate to severe levels of treatment resistance. By chance, our randomization process did produce an imbalance in the duration of current major depressive episode, with ketamine patients having longer episodes. However, patients who received placebo were also slightly more likely to have recurrent depression and to have tried augmentation therapy. Additionally, if there was any concern that very long durations of depressive episode might interfere with the antidepressants of ketamine, this was not or has not been observed in prior ketamine trials, with an example here from the Murrow ketamine study showing still very robust effects in patients with very long duration of depression. Surgical and anesthetic characteristics were also fairly balanced between groups. Most patients had some form of mild systemic disease going into surgery. The abbreviation CCI here stands for the Charlson Comorbidity Index, which is frequently used to classify mortality risk around surgery. And patients here had on average mild to moderate risk of mortality based on their medical comorbidities. The spread of surgical subspecialties is fairly balanced, but not completely equal. But the difference of case numbers between surgical subspecialties was not greater than 3 per subspecialty in a group. With regards to anesthetic type, we asked our anesthesiologist to refrain from using nitrous oxide, as there's been some research showing that it might possibly have antidepressant effects as well. We also excluded patients who were on high amounts of chronic opioids, as mentioned on our eligibility slide, again, because there's some concern that ketamine might have an opioid-based mechanism of action. Of the patients who did use chronic opioids, on average, about 10 oral morphine equivalents per day were used in both groups. But most patients didn't use any opioids at all. And the lengths of surgery was similar between groups. So let's move ahead to the main results of the study. Our primary outcome was depression severity, measured by the Montgomery-Åsberg Depression Rating Scale, or MADRS, measured over the first 3 days following treatment. And we chose to focus on the first 3 days because most studies of a single dose of IV ketamine for depression, the greatest effect, the greatest antidepressant effect is generally observed over the first 72 hours. But we did also measure outcomes at 5, 7, and 14 days after the intervention. We found that both groups on average experienced a rather large decrease in depression symptoms, and that there was no statistical difference between groups. To get a sense of how much improvement was seen, the MADRS score decreased by about 50%, which means that patients who were initially categorized as having moderate to severe levels of depression were then recategorized as having mild depression after surgery. Similar improvements in depression have been observed in other ketamine studies that have similar or even smaller sample sizes than ours. What makes our findings unique is that we found this to exist in the placebo group. This figure shows the proportion of treatment responders in the first 3 days. We define treatment response as having at least a 50% decrease in symptom severity from baseline. And similar to prior ketamine studies, we observed a roughly 50% response rate in the ketamine group. But unlike other ketamine studies, we saw this impressive response in the placebo group as well. To put things in perspective, treatment response rates hover around 30–35% with first-time SSRI therapy, and that rate, of course, drops lower and lower with each failed treatment. So in a population of patients with moderate to severe levels of treatment resistance as ours, this is a rather impressive finding by itself. This figure shows the results of our blinding assessment. So on day 14, after outcomes were collected on that day, we asked our participants to guess which treatment they received. And as you can see, both groups allocated their guesses very similarly, indicating that blinding was successful. Interestingly, the plurality of guesses went towards ketamine, reflecting the sizable drop in depression scores experienced by most participants. So I think this is where things get most interesting. It's not so much the results, but rather the interpretations that us and other people have gotten into a lot of heated debate. What exactly can we make from our results, especially given the fact that there was no difference between groups, but both groups got better? I'll discuss the 3 most popular interpretations that we've encountered from others, and maybe we'll try to refute some along the way. So first, that we hear often a lot is whether ketamine was somehow blocked, maybe blocked by the surgery or blocked by the anesthetic. But just looking at our results, this is rather unlikely since we did see similar effect sizes in both groups as in previous trials. If the effect of ketamine were blocked in our study, we would expect to see basically a flat line in both groups, indicating no change in depressive severity after treatment. But instead, the change we do see is very similar to prior ketamine studies in depressed patients. But the looming question here is, why did the placebo group still improve just as much as the ketamine group did? This leads to another interpretation of our data, which is maybe it's something about the general anesthetics that have an antidepressant effect. And there have been a lot of small and limited mixed studies supporting this. But the key thing here is that even if we take these study results on face value, we avoided a lot of the deep anesthetic doses that have been studied for depression. And we'll go through a few of these. So this is a small randomized trial of about 28 patients that compared nitrous oxide or laughing gas to a placebo gas, which was air in this study. They found that the antidepressant effect of nitrous was significant compared to placebo, but the authors do admit that blinding was not measured in the study and that the sedative and euphoric effects of nitrous are rather difficult to blind. Nevertheless, the findings here can't really apply to our own results since we avoided the doses of nitrous in over 90% of our patients. Here is an open label, non-randomized study where they administered several propofol infusions to 10 patients with treatment-resistant depression. And as you can see, most of them did get better over time. However, they gave doses of propofol that were pretty high enough to induce something called burst suppression, which is an EEG pattern defined by bursts of electrical activity followed by electrical silence. We specifically asked our anesthesiologist to avoid burst depression doses during the maintenance phase of anesthesia using process EEG in our study. And also to note that in general, avoiding burst suppression during the maintenance of anesthesia is standard clinical practice. Here's another open label, non-randomized study looking at isoflurane, another commonly used inhalational anesthetic. The decrease in depression severity was similar to patients who opted to receive electroconvulsive therapy in this study instead of isoflurane. Like the propofol study, the researchers intentionally produced burst suppression by giving very high doses of isoflurane, more than 4%, which is rarely used in adult patients. Again, these findings don't translate well to our study since we did not use such high concentrations. So then, it's easy to ask, what about just regular surgery and regular anesthesia? Can they have antidepressant effects on their own? Well, the podcast study was a large randomized controlled trial done at the University of Michigan with over 500 patients that tested whether a single intraoperative dose of IV ketamine could reduce post-operative delirium in patients undergoing surgery. As an exploratory outcome, they did screen for depression using the patient health questionnaire, and they found that the percentage of depressed patients actually increased following anesthesia and surgery, which kind of refutes the interpretation that anesthesia and surgery have inherent antidepressant effects. Additionally, participants who were recruited for this delirium prevention study might not have been expecting ketamine to improve their mood, which could also contribute to a lack of mood improvement. This explanation centered around expectations leads us to the third interpretation of our results, which is that maybe expectation bias might be driving some of the improvements in depression seen in both groups in our study. This is a very possible and interesting interpretation that I'll spend some time on. So the direction of causality unfortunately remains unclear in our study. We initially actually did not set out to answer this question, and therefore we didn't measure expectations before treatment. However, it's worth pointing out that in a secondary analysis of our data, the patients who guessed that they were treated with ketamine had lower depression scores throughout the study, suggesting at least there was a present expectation of benefit from ketamine. Additionally, there's plenty of other research showing that patient expectations influence treatment response in antidepressant trials. For example, in a study of reboxetine, a novel oral antidepressant, they did find that patients who experienced or expected their treatment to be very effective were much more likely to be treatment responders than patients who had more modest expectations. This leads us to wonder, did most of the participants in our study have very high baseline expectations about ketamine? And what if we could repeat our study in maybe a population with more modest expectations? What would the results look like? Well, one idea is to conduct a similar study in a country that on the whole has much more negative views on narcotics and mind-altering drugs than in the United States. So this is a randomized controlled trial published earlier this year in 2023, looking at whether a single dose of IV-S ketamine, so not exactly the same, but similar, they looked at whether they had antidepressant effects in patients undergoing bowel surgery. And they did seem to find a significant difference in post-op depression scores. Why is that? Why are the results different? One guess is that perhaps there may have been inadequate blinding, since researchers gave ketamine on induction, which is when patients get the first drug cocktail that sends them into general anesthesia. In this case, patients might have been able to tell the difference as they were falling asleep, but it's impossible to really know since they did not assess blinding in this study. The other explanation here, of course, is that there may have been a much smaller expectation of benefit in a Chinese population. So this is where we get out of peer-reviewed research and me typing things into Baidu, which is China's major search engine. But if you type in the word for ketamine, Luantong, you'll pull up all sorts of negative press for ketamine. This is really what showed up on the first page. For those tuning in just by audio, I'll read some of these headlines out because I find them to be rather interesting. So this headline is saying that doctors have found using ketamine to treat depression is a big problem. It's interesting. They're not very enthused by this. And they cite the effects are on the opioid receptor. So actually, I clicked on this link, and it was actually referring to the study by my mentor, Boris, who had found that if you gave naltrexone to ketamine responders, that actually blocked the antidepressant effect of ketamine. This was their twist on it, which was interesting. You also get wild headlines about Musk's recent use of ketamine. It might turn him into a zombie. It's his weird behavior due to his excessive use of hallucinogens. Someone says his life is terrible. And then this link here is talking about, it looks like, the chronic medical effects of chronic ketamine abuse. So it seems like this patient living with diapers is suffering from like a cystic hemorrhagic syndrome that can be seen in ketamine abusers. So as you can see, overall, there's a much more negative view of ketamine, at least based on what people are exposed to. Meanwhile, in the US, things are really different. We just have like a different relationship to mind-altering drugs right now. You have celebrities like Joe Rogan openly embracing ketamine, saturating the airwaves. It's just, really a different environment here. So going back to the big question of whether or not it's the drug or the trip, or is it both, the simple graph here illustrates the traditional view of placebo effect or nonspecific effects in an idealized study with perfect blinding, where both groups experience the same amount of placebo effect, and the patients who receive the active drug get an extra drug-specific effect on top, and the effects appear to be additive. But What we're seeing here across different ketamine studies might be explained by a slightly different model of placebo effect. So here again on the left is sort of the standard view of placebo effect. And in studies with really good blinding conditions and patients with modest expectations, you are able to see a split in the two groups. But in good blinding conditions and where everyone has very high expectations, the placebo effect might be oversaturating the response and hitting a ceiling in both groups. And in studies with poor blinding, which is most ketamine studies out there, you can get asymmetric expectations such that patients in the placebo group get very little placebo effect because they know what they're getting. And patients who did get the active drug, again, their response seems to be oversaturated by expectancy effect. The placebo saturation effect that I described here hasn't been well studied in clinical trials in general, but in the chronic pain research literature, which is where I'm involved, this phenomenon has been documented in a randomized trial comparing propranolol, which is just a blood pressure medication with no psychoactive effects, to placebo in patients with chronic temporal mandibular joint pain. And as you can see, patients who were in the low expectations group at baseline, if they had received placebo, their effects were much less than the patients who actually received the active drug. But in patients who were separated out as having high expectations of pain relief, both groups had similar analgesic effects, which as you can see, looks like the placebo expectancy effect is oversaturating the response. But going back to ketamine and really ketamine-assisted psychotherapy, our current treatment model involves a lot of intensive preparation sessions and lots of high-touch patient contact that might be contributing to expectations. The dosing session, which participants get really powerful reinforcement that something is changing in their brains, also contributes to this. And of course, the integration sessions are also high-touch scenarios in which patients are getting a lot of care and attention. All of this creates maybe a transformative experience, which is probably doing a lot of the heavy lifting in comparison to any intrinsic antidepressant effect from the drug itself. And of course, what makes an experience transformative, you ask? Our study cannot answer this question definitively. However, I'll leave you with this experience from one of our participants who was randomized to the placebo group, but had guessed ketamine at the end of the study. We only had 3 days of data from them, since they did have to go back to the OR for a surgical complication. But despite these challenging circumstances, their mood improved dramatically during the first 3 days. So here's some quotes that we managed to record down with their permission. They said that this trial was a blessing for them. I was mentally strong. I could do all the things that I, wouldn't be able to do. I wish there was a better outcome, referring to the surgical complication. But things that happened are outside of my control or the doctor's control, and I can't be upset about it. And this patient was also, after the surgery, highly productive, taking exams from the hospital bed, when, as you can see by the MADRS score, they were really, really depressed. So just showing that this particular participant went from debilitating levels of depression to acing 6 colleagues' exams from their bed, really, and they received placebo, not ketamine, really makes us ask, what about this was transformative? Something about being in this trial. So I'll end this slide with our research questions again and try to answer them based on what we know. So first, can we use ketamine to rapidly treat depression in surgical patients? You could, yes, and our results do support that, but ketamine may not be necessary, which is seen in our placebo group. The next question of, is ketamine a superior antidepressant to a placebo in unconscious, completely blinded patients? No, but the lack of a difference that we saw in our study might be explained by expectations. And finally, sort of the big nebulous question, is the awake psychedelic experience really necessary to realize the antidepressant effect? And I think our answer is maybe not, but there's something about positive expectations and an experience that may be necessary to have this effect take place. And I'll stay on this slide and end my presentation here, and I'm happy to answer any questions.
Thank you, Teresa. Thank you very much. It was a very interesting paper and a great presentation. I'm sure we'll have a lot of questions coming through the audience.
Yeah.
And I think Rupert already popped some in the chat. But in the meantime, there may be the rest of our audience is gathering some ideas. I also have some questions from my end. I was wondering, I think you mentioned that some people in your cohort received ketamine in the past. Was there any difference between people who received ketamine in the past compared to from the people who did not? Because, you know, we can infer that they were sort of like know what to expect in the following days.
Yeah. So we didn't specifically ask whether those patients who had received ketamine for medical purposes, and then I think, let me go back to this slide so we can see it. None of the participants had received ketamine in a recreational setting. This is all medical. Let me see down. Was it this slide? Let me close this chat.
It was the first one, one prior.
There we go. Sorry, my chat was obscuring my view. Here we go.
Yes.
Yeah. So most participants had no ketamine exposure, or at least didn't remember getting it. But we did not ask those, 6 participants whether or not they could tell in the aftermath whether they had received ketamine. Or that would have been a very good question to ask them.
Sorry to interrupt you, because I was under the assumption, a psychiatrist by training, so that's my bias, that in a medical setting meant they receive ketamine for their depression.
Oh, no. This was all for like surgical procedures or procedural sedation.
Okay. So none of them has received ketamine
for the treatment of
depression.
That's correct.
Okay. So this was just in the context of another anesthesia
that's
that
right.
they received in the past.
Exactly.
Okay, thank you. I think we have some question for you in the chat as it was popping up.
Yeah.
Window. So Rupert has some question initially. I think Boris has already answered, but maybe you can share the answer with the rest of the audience as well, or add if you wish to.
Yeah, that's right. Yeah, we didn't calculate the exact dose of how much propofol and sevo was received, but there were hard endpoints in terms of asking our anesthesiologist to titrate these doses based on their EEG. The key thing is that we told them, use the normal amount that you would use to keep a patient under anesthesia for their surgical procedure, but don't send them into burst suppression using high, heavy-handed doses.
Perhaps you could mention a bit about burst suppression to those who are still new to the concept.
Oh, yeah. So just to keep things not too complicated, so burst suppression refers to the EEG pattern where you get a very characteristic electrical activity pattern where the brain alternates between bursts of electrical activity and then just silence. And you see this with very high doses of anesthetics. And it's basically correct me if I'm wrong, Boris, but it's basically the last step before you give such a high dose where the brain becomes completely silent.
I'll just add one thing. Rupert had another question further down. In general, when you give ketamine on a background of non-burst suppression anesthesia, you typically do not then induce burst suppression. Typically, you see like you mentioned, the suppression of alpha and some beta activity. I don't know if that fully answered your question, Rupert.
It seems he does. Rupert has some difficulty with his internet connection.
Oh, okay. I'll just keep on going down the chat questions here. All right. So I'm not sure. Are people able to see the chat box that I have open?
I think if you have a question in the chat, maybe I think the next one is Keith. Good to see you again, Keith. You're more welcome to ask your question yourself, or we can read it out, whatever you prefer.
And then to answer your question, Teresa, no, we can't see your chat window. But
okay. All right. Yeah, I have it open, but it's not shared on the screen. Okay.
No,
so I'm happy to read out the question.
No. Well, let me just frame. Okay. I'm sure you can read it, and everyone else is reading it too. But
sure.
You're talking about burst suppression and the major implication of expectations, which certainly is part of this. But I guess I'm asking if you could speak to the interpretation that maybe any anesthetic has some benefit in terms of reducing depression post sedation, post surgery, whatever it would be. Although you sort of mentioned how the studies that use deeper doses aren't necessarily analogous to what you saw in your study. I mean, that doesn't necessarily mean that both, strategies, whether deeper or not, or whether using different agents or not, may all sort of have this final common pathway of disrupting brain activity in some way.
Yeah. So
and I add one other
oh yeah,
thing.
go ahead, Boris.
Popped in my head, right? So ECT works for reasons we maybe don't fully understand too, and it's kind of the opposite. It's like excitatory disruption of normal brain activity. So I just wonder if there's some parallel. If you just hit the reset button any which way by any mechanism, that may have some improvement.
Yeah, so I'm just sort of responding to this concern that maybe just regular anesthesia and regular anesthetics still might be able to hit the reset button. And at least the evidence that we have in this delirium trial, which used regular doses of surgical anesthesia for routine surgery, they were not able to find an antidepressant effect. And if anything, they took patients who were generally not depressed, and this population became more depressed after surgery, and probably for a predictable list of reasons, pain, discomfort, loss of function, isolation in the hospital after surgery. So I think it's, based on at least this study, which is very well powered at 500 plus patients, there doesn't seem to be an inherent antidepressant effect of surgical anesthesia and surgery itself.
Keith,
well, the devil's in the details, I suppose.
Yeah.
Keith, I want to add one thing to that. The devil is in the details, and the study has been done like 8 times in 20 years, where mood symptoms have been tracked during surgery. There's the Kudos study. So again, not if you look at the control groups here, again, different questions here, but you're just asking whether surgery and anesthesia are antidepressant. So, right, when you look at the control groups of patients who receive like sevoflurane, propofol, Dex, whatever anesthetic, there is no study that I can find actually, and there have been many, where you see an improvement. If anything, it's flat or actually a worsening. In fact, most of our literature suggests that that the stress of surgery is a risk factor for worsening depression, which was our assumption going into the study. So that's, whether ketamine, like if we had managed expectations whether ketamine could improve it, and then I think somebody posted the Kudos study, that's certainly possible. The Chinese study, again, different drug, not blinded, different doses, they do see a separation that is probably better explained by expectancy than by an intrinsic antidepressant effect of ketamine or of anesthesia and surgery.
Very cool. Again, thanks.
All right. Rupert asked a question about how the EEG was used. Okay, we somewhat covered this about burst suppression. Is it related to alpha suppression, which is uniformly seen with ketamine? You mind if I punt this question to you, Boris?
Sure. I'm not entirely clear on what the question is. Did we see? I mean, when we didn't give ketamine, we didn't see anything. Right. It was just the lines remained flat. Patients remain sedated. So we can't really attribute the reported MADRS score post-op to whatever happened during that infusion, I guess would be the simplest explanation. I may be misunderstanding the question.
Roger asks, is there a follow-up of these patients to look at the durability of effect? Very good question. I mean, I know the literature for ketamine shows that a single IV dose of ketamine hasn't shown durable effect, again, lasting maybe about 7 to 10 days. But we haven't yet formalized a follow-up study for these patients, but we are asking one by one. We're going to make these phone calls to patients again and see how they're doing. Let's see, Tiago asks, or states, the only interpretation I can understand is that you found anesthesia is an antidepressant. Any idea of ECT plus anesthesia plus sham ECT to understand hope in this scenario. I think ECT studies actually are a very interesting and good analogous line of research, because also these participants can be blinded to whatever drug you deliver to them under their brief anesthetic period for ECT. So I do think this is a productive line of research to go down.
I was thinking about this podcast study as well. That delirium usually, I'm an anesthesiologist as well, so I care about delirium on older patients, not in young patients. And
Right.
ketamine has a strong effect on younger patients rather than old patients. And I don't know the podcast study if the mean age of the study maybe match the study your age, the age of your study. If you can just match the age.
I think it was higher. They definitely recruited patients in a more elderly population than our population, but our population isn't particularly sprightly and young either. I think the average age was 50s. Yeah, so we didn't have a terribly young population as well. Now, whether or not a decade of difference has an effect on ketamine's effect, we don't know.
Your population is where ketamine starts dropping the effect, like around 60, 50 years old. And if you don't have any response on placebo group, everything would be easier for interpretation. And
interpretation, right? Why did everyone get better? Is still the big thing?
And why those people doesn't have expectancy on easier things like pills, or I don't know, TMS or prayer. I don't know why they don't have the same. And for a clinical point of view, as a clinician and a ketamine clinician, if this is what it takes to make people better, I wish I could have something easier. But if this is what it takes, this is what it takes.
Yeah, and you raise a good point. Like, these patients are very treatment resistant. Like, why haven't their 6, 7, 8 treatments for depression beforehand actually worked? And I think this might have to go to address the process that these patients went through to participate in this trial, and that it's very similar to our ketamine-assisted psychotherapy paradigm. You know, we see these patients several times before getting the drug. We essentially prepare them for being part of the trial. They get the drug, and the experience is an unusual experience for them. Most people don't live life having surgeries, right? And so going into the hospital and having this thing that is potentially life-threatening coming out the other end, you could view it as like a highly unusual, highly salient, transformative experience for them. And then we follow them after the surgery and the drug administration, again, which is not something that patients usually have. A lot of their doctors don't ask them about their mood and well-being after their surgery. So I think this whole process actually mimics the ketamine-assisted psychotherapy paradigm that a lot of practitioners out there currently use.
But it's still in the usual care of psychiatry. It still have the preparation, the drugs, and the integration. All those steps that usually happen with EMS.
Tiago, I want to disagree with that. There is that these patients were there. You know, it's the level of heightened experience when you close your eyes and jump into an abyss is different than I'm going to go to see my psychiatrist for my 4 p.m. appointment. I mean, this is just what we heard from patients, is that, you know, they're in an exciting trial. We screened 3,000 patients to get 40. These were high, and when we found them, we held them, right? So I think that this is it's hard to scale that level of I guess high touch would be, I like the way Teresa put it. But it feels a little bit different than kind of conventional psychiatric care. I don't know. We didn't measure. We don't know.
Don't you think that then this level of interaction, aren't you concerned, that may have boosted a placebo response?
Oh, absolutely. Yeah.
That's probably what explains the data the best. I mean, if you think about, again, maybe not a great analogy, but you know, in psychedelic trials, like, you have thousands of applicants. You know, are you in the lucky few who win the lottery and get the drug when you're on the couch, or is there a moment of betrayal when you find out you're in the placebo group? And how much of that process in a highly charged environment in an internationally publicized trial can account for the separation in scores. If you look at the Compass phase 2b trial, 7 MADRS points. How much of that was explained by a process like that? It's again, it's much more, there are a lot more factors at play there. But I think it's that's sort of what I'm going with, is that when we're trying to interpret clinical data, it is very difficult to interpret when you have all these non-drug factors at play. And I think unwittingly introduced them into this trial by making it such a kind of expectancy-laden environment.
I'd love to hear what Dr. Irving Kirsch, who studies a lot of placebo response and has books about it, what he has to say about these results and placebo and expectations. I would love to hear what he has to say about it. And from a clinician point of view, I can only think it may be placebo, but if it needs all these steps to people to work and do and get back to life, if that's what they need, I only can give them this. I don't know what other clinicians think about it. I don't know that on basic science, we need to explore further and understand further. But for now, for people who are suicidal and suffering today, what I have is this. So if it's just the expectancy and the hope, come on, let's do it.
Yeah, just a comment on that. I mean, I think as always, there's never going to be a simple, accessible, fully explanatory reason for this finding. By the way, great study, folks. That's a great study. I think that the expectancy point's been made strongly. A report just 2 years ago compared placebo to placebo in the treatment of major depressive episodes and showed that placebo beat placebo with an effect size that would make it the highest effect size of any antidepressant in America. And what they did is they mitigated the expectancy in one of the placebo arms. So clearly it's a big factor. But I think that, I don't know if that's the only thing going on here. I raised the question about the durability, because that's what's so relevant clinically and all of that. But I did wonder about whether there's something about the trajectory of the response. Of course, of course, there's a power issue in the sample size and all that. But the trajectory of the response and the durability of the effect, and that's why I brought that up. But I think that, but look, a fantastic study, just really a fantastic study.
Thank you. Let's see. I want to try to get through as many of these remaining questions in the limited amount of time we have left. Richard asks, is the relief of safe recovery and effective surgery and reduction of pain and disability all potential confounders? Again, I think we discussed in general, study after study, looking at surgery patients, whether or not they got ketamine or not, showed that surgery is just not a pleasant experience. And people may be relieved that they got through and were alive after surgery, but generally people either stay the same mood-wise or potentially get worse after surgery. Let's see. Shuko asks, based on the data presented, it could be inferred that the antidepressant effect of ketamine may be linked to dissociative effects. What sort of evidence makes you think that it cannot be the case? I think the evidence here is just that we're able to reproduce almost the same amount of antidepressant effect in patients who got placebo. So, maybe they were having a dissociative experience under anesthesia. We'll never really know. But I think the way to think about the results of our study is, really closely examining what happened to the placebo group. Rupert, oh yeah, yep, we talked about the kudos study. Raf to everyone asks, given that placebo rates that are generally lower in patients with higher baseline depression, did you look at an interaction between baseline depression and the separation between groups? I think we did just as like a sort of data quality analysis. I was not able to find that baseline depression predicted separation between groups. Rupert also asks, did you control for impact on pain, which presumably affects depression scores? So right now I'm actually doing a lot of these secondary analyses, looking at pain and opioid use. Interestingly, preoperative pain did not predict postoperative depression scores. preoperative pain interference, which is the amount that pain interferes your daily functioning, did seem to predict whether or not you went into the study using opioids, which is consistent with real life. If you have lots of pain interference, you're probably taking opioids, unfortunately. But again, interestingly, pain intensity and pain interference did not predict post-op MADRS scores.
And Lisa, just maybe, I know we're getting towards the end, but
Yeah.
just to clarify, the administration of ketamine, right, in the group that was that received ketamine, was like administered as a bolus, or it followed the similar trajectory of the one that you should administer for trial for depression, like the 40 minutes?
40 minutes, yeah.
40 minutes.
We tried to do it exactly the same as in other antidepressant trials. Same dose, same time of infusion.
And I know you showed that table where there were like a number of treatment failures, but have you like had any look at any data of like other medication, or like people were on concomitant antidepressants, or anything that could have like possibly interfered with the effect of ketamine?
We didn't do any stratification analysis with patients who were on antidepressant or other antidepressant therapies, but we did, at least in our demographics here, show that the prior treatments are about similar in both groups.
But this means the antidepressant they have taken lifetime, right? Am I reading
Yeah,
this
so
correctly?
the Maudsley staging method takes into account how many antidepressant treatments they've tried in their lifetime.
But do you have information about any of them being currently on antidepressants?
We do have that information, but we didn't do any stratified analysis looking at it, whether or not there was an effect.
I think there's another question from Keith. And if you want to read it.
Yeah, sure.
I want to ask it.
It's really interesting, and I agree with everyone else. There's a really well-designed study, and I think it's good discussion that we've had too. It's probably going to be hard to sort out a lot of these subgroup effects with only 20 per group, but don't want to undercut the fact that you guys really nicely designed this. So if expectation is really the big driver of effect, I guess I'm just curious if you have any comments on whether we could somehow therapeutically take that to our advantage. And even if you, in sort of honest fashion, suggest that, your mood may improve after this experience, could that potentially mitigate some of this, what is the normal trend, it sounds like, towards mood worsening after surgery and anesthesia? So that's kind of what I'm left wondering. Previously, I was just giving people ketamine because I thought, well, it won't hurt and maybe it'll improve their mood. But I think you guys have pretty definitively showed that's not a good strategy.
Yeah. I mean, so, before I became a pain management physician, I spent at least, 3 years giving ketamine to patients undergoing surgery outside of this study. And yeah, I've been giving ketamine the same way as you have, which is, well, it might help their pain, it might help their mood, but I'm not going to make a big hullabaloo about it. And yeah, I think maybe we should be telling patients that, studies have shown that perhaps what I'm giving you and how I'm giving it to you might improve mood after your surgery. And, I think more so than just the anesthesiologist, saying a few caring words and giving the ketamine, I think really involvement by like the treatment team, patients who see them before and after surgery. If, in this day and age when we're trying to cut costs and minimize the amount of time that people are in the hospital and being cared for by healthcare professionals, I think some of this, the therapeutic power of contact with humans might actually suffer. And I think, the implications from our study suggest that we should maybe try to go the opposite direction and increase the amount of attention and care that we give to patients when they're undergoing surgery. And maybe that could lead to better outcomes in terms of mood and resulting outcomes from improved mood.
Yeah, totally. And I'm struck by something Boris said, and also your sort of pointing to the podcast, which is a large trial, kind of all comers, I wonder if a highly motivated, patients are the ones that are going to respond, or only a certain subset of, all the patients that come in for surgery will be the ones that are really susceptible to this effect. And maybe, somehow in looking for folks that have pre-existing depression, kind of like selected for that, whereas that effect gets washed out when you have, thousands of patients kind of coming in for routine surgery. But that doesn't mean that it's not an impactful thing to do for those few. So that's the only other thought.
I will say, yeah, absolutely. There's as a heavy selection power or bias happening in our study. As Boris said, we screened a very large amount of people and very few actually qualified for the study. And even of the few who were eligible for the study, not all of them wanted to be in our study. We did have people actually turn away our study, for a number of reasons. Some people just were already overwhelmed, like they're depressed and they're facing surgery, and as a research assistant coming up to them and asking them if they want to participate in a trial, they just can't. They don't want to handle it. Whereas the people who actually agree to be in our study, there's something different about them, right? They're hopeful. They're hoping that they get benefit from this study. They're motivated enough to follow through with the steps required to participate in our study. So our population is highly unusual. And you're right, and there could be some washout effect in a more large generalized study in which you're getting more people, some of which may not be super enthused about being part of a study.
And Lisa, maybe to wrap this up, I think we have a couple of last questions more on the mechanistic side of things.
Oh yeah, here, let me open up the chat here. Let's see. You're talking about the one that Rupert just posted. The propofol and Sevo had continued after ketamine infusion had finished, assuming ketamine was started fairly shortly. Mechanistically, if these interfere with the GABA function, can you speculate on how this could interfere with ketamine? It's certainly possible. We don't have very much data in general about how propofol interferes molecularly with ketamine at, not just the NMDA receptor. We all have to remember that ketamine hits a lot of different receptors. It has effects on HCN channels. There's possibly an effect on opioid channels. So we really don't understand at all how these other anesthetics are interfering with ketamine in theory. But it's a good question. I agree. And Tiago asks, usually the first few minutes of anesthesia is deeper because of the induction propofol bolus. Is this a possible antidepressant effect? Yeah, you do raise a good point. So generally induction will use higher doses of anesthesia, but usually for very short amounts of time, I think, just a few minutes. Whereas these other studies that are sending people into burst depression doses of anesthesia, they're holding these doses for, I think, something on the order of like half an hour, which we usually don't do for induction.
I was just thinking about if you have the PSI recordings and you can see that patients who respond to ketamine or to placebo, they have the first stage deeper on PSI index for deeper anesthesia than those who did not respond to the treatment.
Yeah, that's definitely something that we should look into. We do have PSI data from our process EEG monitors.
You have it all recorded?
Yeah, I think we were able to get data from most of our patients, not all, unfortunately. As you know, sometimes the data isn't saved properly.
It would be a good interpretation if maybe it's just the bolus from the first bolus that you do a lot of opioids, you do propofol, you deepen the anesthesia, you use a lot of midazolam previously to the induction phase. Sometimes that depends on the protocol of the service. But there are more drugs in the initial stage. Maybe that's where the antidepressant effect occurred, and it's the same for everyone. So it really occurred, not placebo, not
possibly, for our study. But again, it's good to keep in mind that other perioperative studies of ketamine and mood have not consistently found an antidepressant effect, and we're assuming that people also use similar induction sequences as our anesthesiologists.
Yes. Your results are very, very awesome. They're awesome and very confusing.
Yes. Yeah. I like to tell people that our study actually raises more questions than it answers.
For sure.